All right, let's dive into one of the most common, and let's be honest, sometimes one of the most frustrating things we see in clinic, the patient with that stubborn, persistent rash. Is it an allergy? Is it just an irritant? Today, we are going to walk through the expert clinical approach, step by step, to absolutely nail the diagnosis of contact dermatitis.
So here's our game plan. We're going to start with the absolute basics, just getting our terms straight so we're all on the same page. Then we'll get into the fun part, learning how to read the skin's story. From there, we'll narrow down our suspects, master the definitive test, and finally learn how to turn that diagnosis into a real, lasting solution for our patients.
Okay, first things first, if you want to diagnose something correctly, you've got to speak the language. So let's clear up the single most common point of confusion right out of the gate. You hear this all the time, right? From patients, from junior residents. Doctor, is it eczema or is it dermatitis? And the real question for us is, does it actually matter which term we use? Here's the bottom line. They're the same thing. Eczema is dermatitis. Dermatitis is eczema. Both terms are just describing a specific reaction pattern, not a single disease. When you look under the microscope, it all comes down to spongiosis, that classic intercellular edema in the epidermis. So you can relax. Use them interchangeably. Okay, so with that settled, we can really split all dermatitis into two big buckets. You've got your endogenous causes, that's the inside job, right? Things driven by internal factors like atopic dermatitis or seborrheic dermatitis. But today, our focus is squarely on the exogenous causes, the outside job, triggered by something that physically touches the skin. And this is where we find our main targets, irritant and allergic contact dermatitis. So how does this process actually look when a patient is sitting in front of you? Well, the skin tells a story, and learning to read its language, its morphology, is absolutely key to our initial diagnosis. In an acute phase, the skin is practically screaming inflammation. You're going to see vesicles, you're going to see significant edema, and that classic weeping or oozing. This is the picture of a marked, recent spongiotic process. Think new onset poison ivy or a really nasty acute allergy to neomycin in an antibiotic ointment. On the other hand, chronic dermatitis tells a very different story. This is the story of a long-fought battle. The skin has given up on weeping and has started to build up its defenses. You get lichenification, that classic thickened, leathery texture from all the rubbing and scratching, and you get scale. This is your mechanic who's had hand dermatitis for 10 years from exposure to epoxy resins. Now, this is one of the most satisfying clues we can possibly find. A linear pattern is practically a signed confession from an external trigger. It tells you exactly how that allergen or irritant was brushed across the skin. You see these streaks? You immediately think poison ivy. It's the ultimate reminder. Distribution is everything. Okay, so now we arrive at the most common fork in the diagnostic road. Is this a true immune-mediated allergy, or is it just direct tissue damage from a simple irritant? Getting this right is crucial. And before we go any further, this number is absolutely critical to remember. Around 80% of all contact dermatitis is irritant contact dermatitis, ICD. That means the vast majority of these cases are not immune-mediated and therefore will be completely negative on a patch test. This one fact frames our entire diagnostic approach. This breakdown right here is critical for your clinical thinking. Irritant dermatitis is just simple damage. Too much soap, too much friction, a harsh chemical. Anyone can get it if the exposure is enough. Allergic, on the other hand, is a much more sophisticated immune attack, a type 4 hypersensitivity reaction that requires you to be sensitized first. And most importantly, listen to your patient. If they say it burns or stings, you should be leaning towards irritant. If they say the itching is driving me insane, you better be thinking allergy. Getting this right in the history saves so much time. So when your clinical suspicion for an allergy is high, how do you prove it? Well, that's when we bring out the heavy artillery, the gold standard, the patch test. Let's make sure we master this procedure. And let's be really clear about this. This isn't just one option among many. For diagnosing allergic contact dermatitis, patch testing is the gold standard. It is the definitive procedure that gives us a clear answer when the history and physical exam just aren't specific enough. The process itself is very standardized, but the real clinical art, the real magic, happens at that second reading, somewhere between 72 hours and a week later. Why? Because these T-cell mediated reactions are slow burners.
Some of our most important allergens, like gold, neomycin, even some corticosteroids, are notorious late reactors. If you skip that second read, you are going to miss the diagnosis, period. And always remember, a positive test is just a piece of data. The final critical step is linking it back to the patient's real-world exposures. Now, to make sure that a positive in our clinic means the exact same thing as a positive anywhere else in the world, we use the international grading system. This gives us a shared, common language for everything from a faint little blush of a reaction to an absolute volcano. So let's really calibrate our eyes to these grades. Okay, so this is your classic bread and butter 1+ positive. You can see the erythema, you can feel the infiltration or papules under your finger, but the key here is what's missing. There are no vesicles. It's a definite yes from the immune system, just not a screaming one. Now we've escalated to a 2+. The game has completely changed. What's the one word that gets us to this level? Vesicles. The moment you see those tiny blisters pop up, you have officially upgraded to a strong reaction. The immune system isn't just sending a polite message anymore. It's on the attack. And here it is, the 3+, the volcano. We've gone way past vesicles, and now we're seeing full-on bullae. The reaction is so intense, it's often spreading outside the boundaries of the original test patch. This is the one you call your colleagues in to see. It is an absolute, undeniable, unmistakable positive. You know, getting that 3+ positive patch test can feel like you've crossed the finish line. But it's not. It's actually the starting gun. The real art of contact dermatology begins right now, turning that piece of data into a plan that actually clears your patient's skin for good. And to do that effectively, you have to know the usual suspects. This list from the North American Contact Dermatitis Group, this is our most wanted list. Nickel is always number one, of course, but look at how common preservatives like MI and formaldehyde are, not to mention fragrances and even topical antibiotics we prescribe, like bacitracin. And this quote really gets to the single most important part of our job. You can forget the high-potency steroids for a minute. Our single most powerful therapeutic tool is education. If we can't effectively teach the patient how to avoid their trigger, we are just going to be chasing the inflammation forever. Education is what truly cures them. And this education has to be practical. It has to be actionable. It is not enough to just say, you're allergic to formaldehyde. We have to provide them with written information, lists of synonyms for the chemical, common places it's found, and most critically, a list of safe alternative products they can buy. This is how we empower the patient to take back control. So I'll leave you with this final thought. This is maybe the most important clinical question we have to ask ourselves after every single patch test. You get a positive result that confirms sensitization. But is that allergy relevant to their current dermatitis? Was it a problem in the past? Is it the active cause of the eruption right now? Or is its relevance still totally unknown? That final step of clinical correlation, that's what separates a good diagnostician from a great one.